Hi everyone, welcome back to Emergency Chaos, where we talk about tips and tricks for new nurses coming to the ER. Today, we will be going over brain bleeds, so stick around. We'll first cover briefly some patho and facts, as well as show some images, and then we'll go into the specifics as to what you as an ER nurse need to be doing to make sure everything that needs to happen for your patient. So, risk factors for brain bleeds include high blood pressure, advanced age, being on anticoagulation therapy, having malformations or deformities of your arteries and veins. So, all of these risk factors essentially lead to the walls of blood vessels being increasingly weak. And if you're on anticoagulation meds, or any minor trauma or any injury can lead to serious bleeding as your body cannot stop it as well. Major causes include trauma, again, high blood pressure, weakening blood vessels, which can ultimately rupture, aneurysms, and even instances of high emotions or activity can lead to a brain bleed in susceptible patients. A brief patho after a bleed happens is that the blood can irritate the brain, leading to a severe headache, seizures, or simply the patient just losing consciousness from the stress placed on the brain by the increasing bleed. And then if the bleed continues to increase, it was going to push against other structures, leading to increased intracranial pressure, which then again leads to a decreased cerebral perfusion pressure, meaning the brain isn't getting as much blood as it would like, resulting in ischemia to the brain and additional swelling. Ultimately, if no interventions happen, then herniation occurs, leading to brain death. And then some of the four types of brain bleeds include epidural brain bleeds, subdural, subarachnoid, and intracerebral brain bleeds. Here, I briefly want to discuss the different layers of the meninges. From the top, it's the dura mater, then arachnoid mater, the pia mater, so that you know exactly where each bleed is occurring when we talk about it. And then it was dura mater, then arachnoid, then the pia mater. And then I just think of it as like DAP, D-A-P for the beginning of each letter. For example, if I say it's an epidural bleed, you know it's between the skull and the dura mater. Or if I say it's a subdural bleed, it's between the dura mater and the arachnoid. Then the same goes for the subarachnoid. Now you'll know it's between the arachnoid and pia mater, covering the brain. And if it's intracerebral, it's within the actual brain tissue and not in the surrounding meninges. This is one of my favorite images because it gives you a really good visual of the types of bleedings and the anatomy associated with each. So if you want, pause the video and study the image for a second just so you can get it inside your head. As an ER nurse, you must be able to recognize the signs that a patient is having a neurological emergency. Sick alter patients will almost 100% of the time get a head CT. But what if you are up in triage and it's your job to recognize an emergency? So let's say a patient is coming in through triage, whether walking in or in a wheelchair being assisted. Be on the lookout for stroke-like symptoms like one-sided deficits, meaning the patient isn't moving or feeling one side, or if the patient is just favoriting one side. Did they complain of a headache or a severe headache or a thunderclap headache prior to becoming altered? Do you know any facial droop or slurring of their words? Are they having balance or coordination issues, meaning they're kind of walking a little wobbly? This can be a sign of a cerebellar issue. Also, note dizziness, with nausea and vomiting. And yes, some of these symptoms can definitely be other things, but it's one of your jobs to sort out any true emergency and at least perhaps conduct a more thorough assessment to exclude some of these other things. Now, what if the patient arrived via EMS and is comatose? You have to note their GCS. You have to note their pupils, because if they aren't pearl, you know something is going on and you must head to CT, right? If after providing painful stimuli, you know they aren't moving one side, but are moving the other, you know something again is going on. And again, you must head to CT as soon as possible to make sure there is no true neurological emergency going on within the brain. And then I'll say here, but always, always, always check a blood sugar on any patient who is altered, as hypoglycemia can manifest as a variety of symptoms. Again, ER nursing basics, ER nursing 101, always check a blood sugar. Going back to head bleed, remember Cushing's triad. I know they talked about it in nursing school, but it can be very important in these situations. So hypertension, bradycardia, and abnormal respiratory patterns. So if your patient isn't moving one side, has crummy pupils, and Cushing's triad is present, you know something is up and must head to CT. Certain facilities want whoever has first contact with the patient and notices these symptoms to call a code stroke, which essentially gathers all the necessary personnel and tells CT that, hey, my patient is priority and should be taken next. While other facilities like a provider to assess the patient first prior to calling a code stroke. So just be aware of what your facility's policy is regarding this. Do note though that you are going to have patients who look great and just have like a little headache going on, but end up having a head bleed. But thankfully, these aren't as common, and you just do what you can, right? Also, note that at some facilities, radiology is amazing and are quick to take your patients in. But at others, you literally have to bug him for them to hurry up or make time to take your patient next, right? So when that does happen, make sure you get the name of the person that you spoke to that said, hey, we're not available yet, so you can chart it as a CYA. So remember that a lot of these things on the screen are going to happen simultaneously. You should be having help, or at least if you're by yourself, you're going to prioritize some of these, but we'll talk about them right now. But most of the time, a lot of these are going to happen simultaneously. When the patient first arrives, as with every other patient, the ABCs will be addressed. If the bleed is severe enough, which a lot of times it can be, the patient will have to be intubated, especially if their GCS score is less than 8. Or simply put, if their mentation is so decreased they can't maintain their own airway. As we've discussed before, this simply means that if the patient started vomiting, could they handle their own secretions themselves, or would they aspirate? Keep in mind which Rsi medications were used. Rsi stands for rapid sequence intubation. Again, keep in mind which medications were used so that you can know when they will wear off, so that you know how accurate your neuro exam is. For example, you just give a paralytic medication. No matter what you do, no matter the stimulus, the patient will not move, which can affect your neuro exam, which is why it is very important for a thorough neuro exam to be made prior to any meds, so that when neurosurgery is contacted, a baseline assessment was already done and communicated from ER provider to neurosurgery. Again, always, always, always check a blood sugar on any altered patient, any confused patient, a full arrest, a little old lady not acting like herself. And then the next most important thing is going to be heading to CT. You have to figure out what's going on. Ischemic stroke, hemorrhagic, a tumor, etc. All right. But if it's a bleed, we have to know what type of bleed it is. Is it epidural, subdural, subarachnoid, or intracerebral? Because some of the specifics and treatments can differ. While all of this is happening, especially after you find out that it's a bleed, blood pressure control needs to happen to prevent any further bleeding and the hematoma enlargement, right? The bleeding from getting bigger. So typically, as for blood pressure management, you're going to see Labetalol pushes of 10 to 20 milligrams, and then a Cardene drip will be started as soon as possible, with parameters being usually keeping a blood pressure below 140. So again, Labetalol pushes and then a Cardene drip started after that. Since you're going to be the one doing the titrating, you know that you want the SBP, the systolic blood pressure, around 140. Because if you drop the blood pressure too much, you're also going to run into the problem of decreasing the blood going up to the brain. And that can cause further injuries through ischemia from the brain not getting the blood and oxygenation that it needs. So it's going to be a fine balance between preventing and increasing bleed and not dropping the blood pressure too much, where you're not letting adequate amounts of blood reach the brain. So aim for a SBP of 140s. If you drop it into the 120s, that's going to be dropping it a little too much. So titrate down on the Cardene so your blood pressure can go up a little bit. Each hospital will have different parameters for titrations for Cardene. So make sure that you know what your hospital's policy is as far as to what to start it at and how much to titrate it by. It's important to know this by memory, because if you ask your dogs what they want to start it at, they may not know, or they may simply say, hey, follow the protocol, which is no shame to them, because they also have a bunch of other things to worry about and do. And titrating and knowing these things is part of your duty, right? But the typical rates that I've seen for carding include starting it at 5 milligrams per hour and titrating it by 2.5 milligrams every 5 minutes as needed to a max of 50 milligrams. And then after everything is important has happened, like going to CT and neurosurgery, seeing the patient and deciding what the plan is going to be, after your patient is intubated and all of that, make sure that you have adequate sedation and pain management to decrease the stress on the body, because the natural response to pain is an increase in blood pressure and an increase in metabolic demand, right? And we don't want that for the brain because it's already stressed out. Other very important things that need to happen are anti-coagulation reversal if needed. Remember that it can happen simultaneously. Your provider will almost always order a seizure prophylactic med, right? Most of the time they'll go with Keppra. Keep a close eye on their temperature, because hyperthermia has also been shown to increase mortality greatly, right? And then there's another medication, nimodipine, which you might see often, and it's going to be used for vasospasms. So now you know what it's for. Now, let's briefly go over what will be done if the ICP is continually elevated and herniation is almost imminent. You'll most likely be administering mannitol or hypertonic saline, essentially to pull water from inside the brain and to give it some room to breathe from all the pressure, right? However, this is only going to be a band-aid, just to give the team time to figure out what they are going to do, whether it's going to be going to surgery or or thinking of something else they're going to do. So mannitol and hypertonic saline come with their own side effects that you need to be watching out for, like renal failure, volume overload, pulmonary edema. But at this point, you're just trying to save their brain so that you can, so you do what you can. If you're unable to control the ICP, then as you know, as we've talked already in the video earlier, then brain death is almost imminent. So what is your job as the nurse? So although we just discussed what's going to happen, let's go over again some of the things you as the nurse need to be making sure happen. So again, checking the blood sugar, heading to CT as soon as possible, placing 2 or more IVs in your patient, because you're going to be giving different medications that aren't compatible with each other. Basics like getting them on the monitor and getting vital signs. And then because you're a good nurse, your room prior to patient arrival would have had an Ambu bag, and otherwise known as the bag valve mask, and suction ready, which are definitely needed when someone is going to get intubated. If your patient does get intubated, make sure that you place a Foley catheter or urinary catheter and an Angie tube. You may also want to grab some soft restraints, since you never know if your patient may have a moment of consciousness and pull out their ET tube on accident. Most important, ensure that you are giving the blood pressure medications ASAP, including the Labetalol pushes and starting the Cardene drip. After everything is said and done, make sure your patient has adequate sedation and analgesia on board. Make sure that the head of the bed is 30 degrees with their neck straight. Keep the environment calm and cluster your care so that you don't stress your patient, leading to an increased BP and heart rate. And then consistently monitor your patient. Monitor their GCS, their pupils, sensation, and motor function. And then keeping an eye out for Cushing's triad, right? If you have a drain in place, make sure you check the CSF output every hour and check the ICP pressure as well every hour, reporting any stripes and changes immediately to your providers. So let's briefly go over the types, right? We want to go over the specifics of each, because there are minor differences. So an epidural bleed is usually from an artery as a result of trauma. So it comes from because it is coming from an artery, a greater amount of drainage and damage and blood can happen in a small amount of time. You may see patients who lose consciousness, come back to it, but then lose consciousness again from the bleeding expanding and putting pressure on surrounding structures. Treatment includes a craniotomy with hematoma evacuation, as well as ligation of the artery that is bleeding. Subdural bleeds are usually from veins, so the bleeding is slow, and as a result, it can take time for the symptoms to show up. Treatment includes a burr hole or a craniotomy with the bulb drain plate so that it can drain out the blood. A subarachnoid bleed is typically known for being the worst headache of their lives and is commonly from a ruptured aneurysm. Intracerebral bleeds, again, can be also as a result of high blood pressure, aneurysms, trauma, or malformations. And then know that older patients can have brain atrophy and can tolerate bleeding inside their head because there is room for it. So they may show up with confusion, a declining mental status, nausea, and other symptoms that these have kind of progressed over time. And again, it's because their brain has the room for the bleed to expand without pressing on other structures as fast as you would for a younger patient. And then while younger patients, even a small amount of bleeding can lead to symptoms, and because there is no free space, right? And then the ICP increases almost immediately. So as far as monitoring the ICP, it's going to occur after a device is placed within the brain of the patient, which can be a ventriculostomy or an EVD, which stands for external ventricular drain. These are great. The EVDs are great because you're able to measure the ICP while also drain CSF fluid, which helps lower the ICP. Other methods of measuring include specific bolts and catheters. However, they lack the ability to drain CSF. Once you have an EVD with your preceptor, make sure that you take great notes on how to zero it and which way to turn all the knobs so that you can refer back to it once you're on your own. So again, it's very important for you to take amazing notes when you have an EVD with your patient, with your nurse and preceptor, so that once you have one when you're on your own, you're able to turn back to these notes. So as far as the pressure, anything above 20 is elevated and you have to contact your team for further instructions, which can be specific meds like mannitol or hypertonic saline, draining additional CSF, or heading to surgery, right? So again, if it's ever above 20, you have to contact your team so you can get further instructions. And it's going to be mannitol, hypertonic saline, draining additional CSF, or heading to surgery. Remember that if the ICP stays elevated, brain death will eventually occur as a result of pressure on structures, herniation, and lowered CPP, causing ischemia. So make sure you check the ICP every hour and hustle the providers when you need to for an intervention. Don't forget to CYA by charting exactly who you spoke to about your concerns. You want to protect yourself and your license because you know you're doing the right thing. CPP is calculated by subtracting ICP from the MAP. And the MAP again is from the blood pressure, right? So you want a CPP or cerebral perfusion pressure above 60 or around 60, but not less than 50, because 60 is the least amount of pressure needed to ensure that the brain is still getting enough perfusion and not being ischemic. You may have to increase your blood pressure to ensure your CPP is adequate, and at times I've had to use pressors to do that, and doing the interventions about decreasing the ICP, like we've talked about, like the draining additional CSF, mannitol, hypertonic saline, that kind of stuff. But the team needs to be aware of what's going on so that they stay ahead of what's going on and plan and direct the care right. Okay, now we're going to go into the question of the day. So, okay, if you're here after all of that, you're for sure committed. So for the question of the day, we have, what is a strong pain medication that we can give to patients in severe pain, but who have a soft blood pressure? So again, they're in severe pain, but their blood pressure is kind of soft. The answer is going to be at the bottom of the description. As always, thank you for your time today. If you enjoyed the video or learned something from the content, I would really appreciate a like and a follow. And if anything comes to mind as far as things that you would like me to cover, please leave a comment below. I would really appreciate that. Also below in the description, I've listed my favorite ER nursing related books, and maybe you're going to like them too. I think that being a good ER nurse depends on your experiences, but on also taking the time to look up things to familiarize yourself with topics that you don't fully understand. So always keep learning, okay? And then as always, teamwork makes the dream work. And here at Emergency Chaos, we are proactive, we stay ahead of everything, and we are not reactive.